We have an exciting topic today that hopefully a lot of people are joining and interested in. We've had a very high level of registration. I want to introduce the moderator and leader of this topic, who's a colleague and friend and a very accomplished orthopedic researcher. Jody Buckwalter, a longtime chair of orthopedics at the University of Iowa, and now the principal investigator of the only Department of Defense sponsored research center in post-traumatic osteoarthritis, has served as a leader of many professional organizations within orthopedics and orthopedic research, just about everyone you can imagine, to be honest. He's past president of the Orthopedic Research Society, the American Board of Orthopedic Surgery, and American Orthopedic Association. He's won the Kappa Delta Award, the Orthopedic Research Society Distinguished Investigator Award, and the Bristol Myers Squibb Zimmer Award, highlighting his outstanding orthopedic research. In addition, beyond orthopedics, he's been elected to the Institute of Medicine and the National Academy of Sciences. Jody is really, among the world's leaders, if not the world's leader, in our understanding of the pathophysiology of post-traumatic osteoarthritis, a problem that is most obvious and evident in military personnel, although it's much broader than just affecting the military. And with that, let me turn it over to Jody, who I know has a panel of people who will provide a lot of insights.
Jody, you're on mute, I think.
Yeah, sorry, I got it. Sorry. Well, David, that was overly generous and very kind introduction. I have really appreciated working with you and your critical insights into the whole problem of osteoarthritis, as well as your way of analyzing complex ideas and presentations. And it's been such a pleasure to write a few little book chapters with you and share your thoughts. And it's been a wonderful professional and personal friendship, which I appreciate very deeply. And congratulations, David, on this well-deserved award. That's really great news, and makes me very happy and very pleased that you've received that recognition. Well, very briefly, the focus of our forum today, as the title says, is on osteoarthritis in military personnel and veterans. Osteoarthritis is the most frequent disabling condition leading to discharge of military personnel from active duty and the most common cause of permanent disability in military personnel. Athletes, firefighters, laborers, farmers, like military personnel, suffer a high incidence of osteoarthritis. Importantly, in all these groups, disabling osteoarthritis, particularly of the lower extremity joints, develops more than 10 years earlier than osteoarthritis in other populations. So it occurs at a time when these people are in the most productive and demanding years of their lives, and physical activity is often critical to their jobs and their personal lives. In all of these populations, it appears that joint overload, joint overuse, and joint injury have important roles in initiating the processes that lead to osteoarthritis. Yet, there is much we don't understand about how these factors cause OA, and very little understanding of how to prevent or minimize OA risk, or how to treat the disease in its earliest stages before it causes crippling joint destruction. The purpose of this forum is to take a multidisciplinary approach to these challenging issues, with the ultimate goal of stimulating work that leads to better ways of minimizing the impact of osteoarthritis in these at-risk populations. We are very fortunate to have a panel that brings extensive experience and knowledge to the spectrum of OA research and treatment. Military service and treatment, people with experience in military service and treatment of military personnel, orthopedic surgeons, rheumatologists, sports medicine specialists, exercise science, public health, OA basic translational and clinical research, epidemiology, physical therapy, and orthotics. So it's a remarkable assembly of very experienced, thoughtful people. As David mentioned, I'm an orthopedic surgeon. I've had clinical experience with the treatment of joint injuries and osteoarthritis. And as David mentioned, my research has focused mostly on post-traumatic osteoarthritis. So now I'd like to have the panel members introduce themselves. Let me just give a quick overview of the program that will go through a presentation of the overall impact by Ken Cameron. And then we have a series of discussion questions that will enlist input from the panel members as well as the participants. So I think it's going to be a very full program. I think we will learn some fascinating new thoughts, but we also need to identify what we don't know that's important, what we do know and what we don't know. So I'd ask the panel members to briefly introduce themselves, presenting a summary of their background and experience, starting with Ken.
Thank you. My name is Ken Cameron. I'm the Director of Orthopedic Research at Keller Army Hospital at West Point at the United States Military Academy. And I've been involved in some of our research efforts related to osteoarthritis and post-traumatic osteoarthritis, particularly following joint injury. And thanks for the opportunity to join the panel and to hopefully get the discussion started today.
Nancy Lane. Nancy? Well, maybe Nancy's not on. Maybe Christian, could you introduce yourself?
No, I'm sorry, I'm here. I was
Oh, yeah.
muted
Okay.
and delayed. Hi, Nancy Lane, University of California, Davis, rheumatologist, like a little bit like David, been studying the epidemiology of osteoarthritis for many years and involved in translational studies of medicines with different mechanisms to slow the disease course. Thank you.
And then Christian.
Yeah,
Christian,
can you guys hear me now?
Yes, yes.
Okay, because sorry, I'm not sure. There was two unmute buttons that showed up here. Sorry. So yeah, thank you very much for giving me the opportunity to be part of this great effort. My name is Christian Lattermann. I'm the Chief of Sports Medicine at the Brigham and Women's Hospital in Boston. I'm an orthopedic surgeon, sports medicine specialist. I consider myself a physician scientist. I do both clinical outcome studies as well as basic science work in the field of post-traumatic osteoarthritis with a particular focus on inflammation. I have a particular interest in understanding the role of inflammation in the synovium in the context of early osteoarthritis, very early after initial trauma, specifically ACL injuries. I'm a cartilage repair specialist, so I run into this problem all the time from a practical perspective in the clinic situation.
Thank you. And I'm sorry, Dr. Marshall.
Thank you. Good afternoon, everyone, or good morning if you're in a different time zone. My name's Steve Marshall. I'm based at the University of North Carolina. I'm an injury epidemiologist. I direct a research center called the Injury Prevention Research Center at UNC. And I've collaborated with Dr. Cameron for more years than either of us would like to confess to on a number of studies in this space. And I think, you know, this is a wonderful topic, a really important topic. I really appreciate the Arthritis Foundation, for bringing this together, and look forward to a stimulating conversation this afternoon.
Thank you. And Jessica?
Yes, good morning. My name is Jessica Rivera. I am currently faculty at Louisiana State University in New Orleans and also affiliated with the Southeast Louisiana Veterans Healthcare System. Prior to these assignments, however, I was in the U.S. Army and served for 11 years as an orthopedic surgeon there in the military. I've during that time and ongoing into the real world, if you will, I focused on injury epidemiology, specifically combat injury epidemiology, the resultant unfitting conditions that cause our service members to be medically discharged or retired from their service, and also how that extrapolated into the veterans healthcare system in terms of service-connected disability and ongoing overall disability.
Thank you very much. So good to see you. Jason?
Sure. Good morning. My name is Jason-Wilken. I'm an associate professor at the University of Iowa. I appreciate the opportunity to join the panel this afternoon. So I spent approximately 12 years at Brooke Army Medical Center running a research program for the Department of Army, working with injured service members, particularly individuals who had experienced traumatic injury, including amputation and other blast injuries. My current research focuses on carbon fiber bracing and other rehabilitation strategies to help kind of mitigate the effects of some of these initial traumatic injuries.
Thank you very much, Jason. So now we'll turn to Ken, and Ken's done a tremendous amount of work on looking at the impact of osteoarthritis in military personnel and has written several really valuable articles on the subject. So Ken will give us an overview of the impact of osteoarthritis in military personnel.
So we'll try and start sharing here. Everybody see the slides?
It looks great.
Yes, looks great.
Yes.
All right, great. So this is our topic, and I'm again honored to have the opportunity to talk about this and share some of the work not only that we've done, but that some of our colleagues on the panel have performed in this area. So obviously, I work for the government, and anything I say is my own opinion and is not the official opinion of the government. To get that out of the way. But today I'd like to provide a brief overview of osteoarthritis and the impact that the disease has, particularly in military service members and veteran populations. I'd like to discuss the risk of acute traumatic joint injury. We've already talked a little bit about that in military populations and the relationship between those types of injuries and osteoarthritis. We'll look at the incidence and the burden of osteoarthritis in military populations, and we'll discuss potential contributing factors and prevention and management strategies within this unique population. And then finally, I'd like to discuss, or at least start the discussion of strategies for the primary prevention of joint injury and the secondary and tertiary prevention of post-traumatic osteoarthritis following joint injury. So we've talked a little bit about this, but what is post-traumatic osteoarthritis and what does it look like? Typically, it may be a unique phenotype of osteoarthritis that has its own characteristics, but it's typically seen after joint injury. It typically follows a much shorter time course, as Dr. Buckwalter spoke about, and typically it affects people much younger in their age and affects their quality of life. Some of the estimates that are out there suggest that around 12% of osteoarthritis is due to post-traumatic onset, and lower extremity post-traumatic osteoarthritis costs approximately $3 billion a year in direct healthcare costs. Indirect costs are obviously substantially more on top of that and affect adjusted life years of quality life and disability. And also, we know, particularly in these younger individuals that develop osteoarthritis much earlier, that they're not only at increased risk for primary joint replacement, but also potentially revision joint replacement. So it's a significant burden on individuals who are in this category. And there's very solid evidence to suggest that joint injury leads to much higher risk for osteoarthritis following joint trauma. And that's in the upper extremity and the lower extremity. We probably hear more about it in the lower extremity. And there's also good evidence, like I said, that this happens at a much faster rate than we typically would see with primary osteoarthritis. We also know that the military population is at very high risk for joint injury. And a lot of times we think about this in terms of battlefield injuries and injuries to the joints that happen on the battlefield. But the vast majority of joint injuries in military populations occur during physical training, during military training, during recreational activities. The overall number of these types of injuries are much more significant, but they're no less important, and they still contribute to the initiation and progression of this post-traumatic osteoarthritis in this population. And these types of injuries are also by far the leading cause of medical evacuation from recent operations in Iraq and Afghanistan. By far greater numbers resulted from these types of injuries being evacuated than from battlefield injuries themselves. So, joint injuries, I think we can all agree, are pretty common in military service members. There's good evidence of that. And there's good evidence that people who have sustained a single joint injury are much more likely to sustain a subsequent joint injury, and that these injuries really contribute to decreased function and higher rates of disability. So we know that there's a lot of joint injuries in the military. It's a common problem, and we know that post-traumatic osteoarthritis is a common outcome from these joint injuries. But what does it really look like in terms of in the military? So some of the studies that we've done, again, we've seen a significantly higher incidence rate of osteoarthritis in military service members compared to the general population, and similar results have been reported in Veterans Affairs populations. Again, we think this may be due to high rates of joint injury, which we'll talk about in a little bit more detail as we get further on throughout the presentation. And as Dr. Buckwalter spoke about previously, the vast majority of people who undergo joint replacement in the military, active duty folks under the age of 50, those are typically traced back to joint injuries, particularly in the knee joint and the ACL and the meniscus. And knee joint injuries are very common. I think we've documented that pretty well. And they're also cause of a medical event. We've done some systematic reviews that have looked at this and again, documented the higher incidence of OA in military populations. And as I said before, because of the high rates of joint injury, we also wanted to look at this. And we saw that there were significantly higher incidence rates at all age groups in military service members compared to the general population. When our colleagues looked specifically at target joints of interest, like in the hip, again, we saw that there were significantly higher incidence rates of OA in military service members compared to the general population with comparable ages. So in males, we saw an incidence rate that was about 4 times higher, and in females, again, we had a pretty wide confidence interval for that, but even much higher than that. So again, we wanted to trace this back to joint injury. The estimates of post-traumatic osteoarthritis in the knee joint specifically have been around 10% prevalence in the general population. So we wanted to look at that in the military population. So we utilized some information from the Total Army Injury and Health Outcomes database to do that. And when we looked at that, we saw very similar results to what's been reported previously, that individuals, once they started active duty, if they sustained a knee joint injury, they were 6 times more likely to be diagnosed with osteoarthritis during their military career. And these are some survival curves. Again, the red line shows cases of post-traumatic osteoarthritis in the knee after knee joint injury. The blue line is primary osteoarthritis with no history of knee joint injury. Some of the take-home notes when we looked at this is that the period prevalence in the military service members was closer to 36% of those OA cases in the knee were due to joint trauma, whereas again, 10% in the general population. That was a significantly higher prevalence in the military. Also, we saw that the time from injury to OA diagnosis was the median time was 31 months, which is again a much shorter time course than we would typically think about for individuals with a knee joint injury. And finally, we saw that the incidence of PTOA in the knee, soldiers were 31% more likely to receive a disability discharge after knee joint injury and PTOA, and they were likely to receive that at a much earlier age. Now Jessica's on the call, so if I say anything wrong about some of her studies I'm going to talk about, I'm sure she'll correct me in the discussion. But her and her colleagues did a lot of great work to look at disability and disability discharge related to orthopedic battlefield injuries and just overall osteoarthritis disability. So we'll talk briefly about those. But really from these battlefield injuries, which are typically more complicated than some of the sports-related joint injuries that we talk about. They may affect multiple systems, but ultimately the highest, the most frequent disabling condition remained arthritis, which primarily was osteoarthritis. When they looked at the percent disability, again, that was around 15% on average for those cases. And when they multiplied or looked at the frequency or how common that is compared to the disability rating that people received, the overall impact, placed osteoarthritis near the top of the list in terms of disabling conditions and the impact that they have in military populations. They also looked at post-traumatic osteoarthritis caused by battlefield injuries. And again, nearly 95% of the cases were the result of battlefield injury, were not attributed to things prior to that. And even more advanced than what we saw with the knee joint injuries, osteoarthritis typically was identified as a disabling condition on average 19 months later. So we're talking about a very rapid progression to disabling condition after these types of potentially polytrauma injuries that include the knee joint and trauma to the knee joint. So they also looked at whether or not after a decade of combat operations in Iraq and Afghanistan, how that affected disability discharge ratings in the military. They looked at 2001, the first quarter, and also 2009. And I think the shocking take-home message was that after a decade of combat operations in these theaters, that still osteoarthritis and back pain were the primary drivers of disability discharge in the military. They did report a significant increase in the average percent disability rating that was received for osteoarthritis during that time period. And again, when you looked at overall impact, back pain and osteoarthritis remain near the top of the list. So a frequency of this disability diagnosis, as well as the percent disability that they were receiving for this. So I think, the take-home message is that, despite our different perceptions of the types of combat injuries that are occurring and the outcome of those, that after a decade of combat operations, almost that osteoarthritis and back pain remain the most significant drivers of disability discharge affecting force readiness in the military. So we might want to think about why we see this significantly higher incidence rate in the military. There are several reasons. We already talked a lot about joint injury. I think that's a driving force. As Dr. Buckwalter talked about, these folks are engaged in occupational demanding activities and physical training that require a lot of bending, kneeling, squatting. So these types of activities we know are a risk factor for osteoarthritis. And we know that obesity is a risk factor. And while military service members are required to meet height and weight standards, the typical combat load is significant in terms, ranging from 52 pounds to well over 100 pounds. So we take young and fit individuals and we put a load like this on them. We can obviously see how that affects mechanics as well as ergonomics, but we don't really know the long-term outcome or impact of these types of activities or this type of loading on the joints. And I think this is probably something we definitely need to understand better. So how can we think about mitigating this? Obviously, we've talked a lot about joint injury. If we can prevent those joint injuries in the first place, so focusing on primary prevention, we can prevent a lot of the osteoarthritis that we see in this population. We can develop effective and evaluate effective secondary and tertiary prevention efforts. And I know that the panel is going to talk a lot about that. So what can we do after joint injury to alter the course of the development of post-traumatic osteoarthritis? And then finally, obviously evaluating the impact of standard combat loads and finding ways to alter those and what the impact of those are on joint health, both near term and long term. I also think it's important for us to think about prevention in different levels. So primary prevention is really focusing on what can we do to prevent the disease in the first place, prevent an injury from happening in the first place. If we can do that, we'll get a lot of bang for our buck. But once somebody has sustained an injury or once somebody has started to develop degenerative changes, then what are the things we can do to alter that progression? So there's good evidence, particularly from the sports medicine community, that we can do things for primary prevention to prevent knee joint injury in the first place, and that may have application in the military. I know the OA Action Alliance has put out some information, some of the based on the best science that's out there about critical things we should think about in terms of this primary prevention. And is there a role for screening and intervention in military populations, just like there are in some of our athletic populations? But as one of my colleagues likes to say, once somebody has actually sustained that joint injury, at that point the horse is already out of the barn. There's not much we can do about it. So we need to start shifting our focus to secondary and tertiary prevention. What are the things we can do right after injury and in that time period after injury until the disease really starts to progress to alter the course of that potentially. And some of those things are already out there. This is the public health agenda from the CDC. So some of the things we can focus on early are weight management, obviously after a joint injury, self-management techniques, and moderate or modified physical activity where possible. And there's also been a shift recently in the way that we look at managing osteoarthritis that addresses this secondary and tertiary prevention concept by treating it more as a chronic disease and using a chronic disease model over time instead of waiting for advanced disease to develop. And I know that a lot of smart people probably smarter than me, have also been talking about this and kind of shifting our focus in terms of how we think about osteoarthritis after joint injury. There have also been a good systematic review about interventions that are available for early osteoarthritis or early in the stage of osteoarthritis, which may be applicable to post-traumatic osteoarthritis in military populations. And this is the key take-home note, I think, is that there's essentially good agreement on many recommendations for management, but they're not really well adopted or implemented, in clinical practice. So how can we improve that to potentially alter the course of this disease? And I think the panel is going to have a lot of discussion about, what can we do earlier on in the time course to identify people who are more likely to progress rapidly, and how can we potentially intervene? And I think in order to do that, we really need to better understand the role of biology, the role of the structural changes that have occurred, and how loading is altered in the joint potentially following injury. So I think we know a lot about those, but those are areas, and particularly how they interact, that we still need to learn a lot more about. And so just to summarize, I think post-traumatic osteoarthritis is a unique form of osteoarthritis that is particularly common in military service members. Acute joint injuries, place a significant burden on active duty soldiers. They affect force readiness, and they also affect our military veterans as well. I think that these types of injuries are things that can have a long-term impact. And we really need to focus on ways that we can prevent injuries from happening in the first place. Obviously, we can't prevent all injuries, but there's a lot that we probably could. And then what can we do after joint injury occurs to alter the course or preserve joint health going forward? And then how do these chronic management models, how can they be implemented potentially to help us better serve our patients and preserve their joint health? And I think that's all I have, so I'll turn it over, and I'm sure that the panel will have a lot to add to that and fill in some of the gaps potentially that I skipped over and correct any of the mistakes that I may have made. So thank you very much.
Ken, that was great. I really appreciate it. You've done such a fantastic amount of work on this, and I'm sure other panel members will have comments. But within the military, and questions, within the military population, is there some subset of people that are particularly at risk?
So is that a question for me?
Yes. Yeah. Well, I just thought I'd start it, and then everybody else can join in.
Yeah, no, I mean, I think obviously there are probably some occupational specialties that are increased risk for joint injury. Also at increased risk for the types of loading that we think about when we think about military combat loads. So I definitely think there are some groups that probably are at greater risk, but just overall, I think the population as a whole is at increased risk just because of the nature of the work that they do, the things that they're asked to do, and the type of training that they're engaged in on a regular basis.
Will come from other members of the panel or the participants?
Sure, I can jump in next. So I think there's, well, first of all, thanks for the great presentation. It's a really nice overview of where some of the challenges lie. I think for me, three groups come to mind in terms of the risk, especially associated with high energy, lower extremity trauma. And so the first one that comes to mind is individuals who've experienced an amputation and concerns for the contralateral limb, specifically the contralateral knee, where they see increased rates of knee pain and osteoarthritis down the road. And so figuring out what treatment strategies are most appropriate for that group to prevent that essentially secondary change or secondary effect of that amputation. Another group that's really been the focus of some of our work and I think is receiving quite a bit of attention is the individuals who've experienced this high energy, lower extremity trauma that has multi-system effects, whether it's volumetric muscle loss, nerve injury, and others, and really allowing them to engage in those physical activities and restore some of the function that we know is beneficial for individuals who have experienced arthritis. And so one of the multiple options is carbon fiber bracing, where you can essentially support them and protect the joint and keep them out of the pain-free ranges until the point that they can recover some of that function and potentially have a better outlook. And then really the third group, I think, is one that isn't touched on very often, is potentially using carbon fiber bracing or other approaches to prevent that rapid development of post-traumatic osteoarthritis. So I think the work by both you and Dr. Rivera really highlight how fast this post-traumatic osteoarthritis occurs in the ankle. And so I think there's options for essentially providing mechanical support to decrease the contact stress at the ankle, which would then, again, prevent the development of arthritis.
I would agree with everything that's been said so far, and definitely say that in terms of the at-risk populations, we're looking at our entire military, because yes, we have a small subset that we can say had traumatic injuries that caused a post-traumatic arthritis. But depending on your definition of post-traumatic arthritis, we have an entire population of military service members who have a training load that they may not have been used to until they joined the military, or other just occupational demands that is unusual to the larger population. So I feel like the at-risk population are not only those who are deployed and may have very high energy trauma imparted upon them, but those who are just bearing the load from an occupational standpoint every day.
Yeah, and I think that's a good point. I think the other aspect is, once these people, if they do sustain injuries, even just an ACL injury, we're able to fix that, repair that, get them back to a high level of function. But then we put that type of loading back on them again after we know they've already had a trauma to that joint. So what is the impact of that? We don't really know, what that is. And we definitely need a better understanding of that and how we can potentially mitigate that.
We have a question from Laura. Does the military still utilize the ammo can lift to assess upper extremity strength? Jessica or Ken, do you know?
So I think they've just transitioned to what they call the ACFT in the Army, at least the Army Combat Fitness Test. They don't have the ammo can lift, but they have a deadlift. So, I think there are a lot of mission essential tasks that they'll do with training that may result that may be similar to an ammo can lift, but they don't use that specific lift to assess fitness, as far as I'm concerned, as far as I know.
Well, we have a question from Terry McInerney. The table scoring frequency of the top 10 causes of disability, it mentioned knee independently of OA as a top cause. What is the pathology or knee problem that is not OA that is causing frequent disability? And thanks for a great presentation to you, Ken.
Yeah, so I think we kind of get into the, I guess, the mixed discussion of joint injuries to the knee probably, and then the progression of those, either, potentially we were unsuccessful in restoring stability, or we see that those injuries progress fairly rapidly to osteoarthritis or lingering disability. So, I think a lot of those, the reason that there's a high rate of those is because, the knee is injured fairly commonly. And then, obviously Jessica can probably add some more to that, as well as Jason, if they have any comments.
And I think that this is a great question, and in fact allows us to highlight that probably a knee OA, an other joint OA, is a bigger problem than we can even put a number to. Having worked with some of the service-connected disability descriptions, as well as the medical discharge data from the Army, specifically the Army Physical Evaluation Board, those types of conditions, their unfitting conditions or disabling conditions, are categorized in such a way that sometimes it's very clear to understand what they are, and sometimes it's not as clear to understand what they are in terms of the underlying diagnosis. Like, as clinicians, we think of diagnosis codes, and this is different. These are different types of categories. I would say then, if knee OA is or osteoarthritis is one thing, knee conditions that may seem very, very vague, particularly that can be linked back to a documented injury, even if they are not described by the Physical Evaluation Board or the VA service-connected compensation exam type coding, will inevitably be OA. And so these conditions that sound kind of vague, or even problems that are documented with loss of range of motion, which is like a big lumped category in this type of language. I'm trying to think. Loss of motion and then just other more vague conditions are oftentimes, from a clinical diagnosis standpoint, OA. So I think the problem is bigger than we can even describe by these types of numbers.
That's certainly my sense, Jessica, that it's a bigger problem than we are even able to track.
Yeah, I think Dr. Goodman and colleagues did a really good study, interesting study, where they looked at a brigade combat team that deployed, and they looked at them coming back, and there were a lot of significant trauma injuries to the knee, to the shoulder, that really they didn't report when they were in theater. So they were people who probably would have been evacuated if they'd reported. They didn't report those injuries till they got back. They found out about them on their redeployment evaluation, and a lot of those required surgery. So, there's a lot of injuries that probably also occur that really aren't documented because service members don't seek care for those injuries.
Are there other comments on Ken's really impressive presentation?
Hey, this is Steve Marshall from University of North Carolina, and wanted to just chip in with a couple of thoughts. Certainly congratulate Ken on a outstanding presentation here. I wanted to take a step back and kind of offer a perspective about the military as a workforce. I think as many of us have staff that we manage, and we're used to saying to our staff, you are our greatest resource. Our people are our great resource. I think the military is an interesting workforce in that we tend to invest in a lot of machinery and gadgets. So it's an occupation in which the people who invest in this are you and I, the taxpayers. And what we're purchasing is person expertise, but also a lot of hardware. And Ken showed you those photographs of the loads that are placed on service personnel in active theater. And we're looking at substantial loads there. And, by the time 50 corporations have built a gadget that weighs 2 kilos, that's 100 kilos that someone has to carry around. And that extra weight, if we know two things about osteoarthritis, is that weight and injury is bad. And in this population, we seem intent on giving them lots of both of those risk factors. Very unfortunate.
Are there other comments? Excellent comments, Steve. Thanks very much. Other comments on Ken's presentation and the overall impact? Oh, we have a question. A question from Deborah Andio, to everyone, how often is knee OA and osteonecrosis of the knee from trauma overlap? So how often is osteonecrosis overlapping with knee OA?
I do not know.
I think I can take that question as a clinician. So, I mean, generally, I think they are essentially different pathologies, and there may be some overlap, but there's no causality between the two. Osteonecrosis can lead secondarily to knee OA if it affects the actual joint surfaces, but it's actually a disease that typically starts in the depth of the metaphysis of a bone. And leads to essentially bone death that then secondarily affects the joint surfaces. There's a whole myriad of different reasons why osteonecrosis obviously develops, and there's various different theories about it. But the direct connection between osteonecrosis and osteoarthritis is really just essentially once the osteonecrosis penetrates into the joint, and then it's a secondary effect of an actual damaged structure. So no true overlap in the pathogenesis per se. The treatment for the osteonecrosis, once it is affecting a joint, it's the same treatment that we do pretty much for any other joint that may have an osteoarthritis-related defect that can be either trying to fix the defect or is eventually replacing the joint. Typically, when osteonecrosis affects a joint, it is too large to be successfully treated with things like non-operative, measures such as injections or so, because it actually affects the mechanical integrity of the joint. Jody, I'm sure, I mean, you have seen as many of these as I have, if not twice as many. If you have to add any to that, then I would appreciate that.
Well, we certainly, as you know, Christian, we see osteonecrosis in patients who develop end-stage osteoarthritis, but obviously the relationship, I think as you said, well, it seems to be a little bit a different disease. Would you agree with that?
Yeah, absolutely. I think one confusion that has been coming up lately is that there is an entity that a lot of us, and I know David has published on this also, have kind of sort of focused on for a while, which is what we call bone edemas or bone bruises, which can often and sometimes be misread as osteonecrosis. Those are two different things, even though they may end up in very similar end stretches. It basically is a progressive weakening of the subchondral bone structures. And that is obviously closely associated with osteoarthritis, but I think this is a different pathology.
Oh, thank you very much. Any further comments on the overall impact? If not, we can proceed to the discussion questions, which are on the slide, and discussion issues. And the first is, what do we know and what do we not know about how mechanical injury or overload causes osteoarthritis? If we understood that well, we would perhaps have effective ways of treating it. So I'll just start. There are multiple thoughts and possible mechanisms by which joint injury or joint overload causes biologic changes that lead to osteoarthritis. Our particular interest in our group has been looking at oxidative stress, and in a series of laboratory experiments, animal experiments, ex vivo and in vivo experiments, we found that injurious mechanical loads applied to the articular surface are transmitted through the extracellular matrix, across the cell membrane to the cytoskeleton, and then to the mitochondria. And these loads trigger production of reactive oxygen species that will cause cell dysfunction and even cell death. And chronic overloading can cause chronic mitochondrial dysfunction. And in one series of experiments, our research team, not me, but other members of the team, showed that chronic overloading led to changes in mitochondrial function well before the appearance of osteoarthritis. So our particular interest has been on the role of mitochondria and oxidative stress in leading to osteoarthritis, both in acute joint injuries and in chronic overload. And it seems that that mechanism has an important role in the development of osteoarthritis or post-traumatic osteoarthritis. But there are other perspectives, and Nancy or Christian, you might want to comment on inflammation and synovitis and a broad perspective on biologic mechanisms that lead to post-traumatic osteoarthritis.
Yeah, this is Nancy Lane, and Jody, I agree with you that that insult in that resulting oxidative state resulting in mitochondrial loss of function or number. And my question is, you guys have done such a great job with the cartilage. Has anybody looked at the bone and the muscle and looked for those biochemical changes around in the acute setting?
We have not. I think Christian mentioned things like bone edema and those changes in subchondral bone. But no, we have not, Nancy.
Yeah, because as you mentioned, the synovitis is probably driving a lot of the changes seen within the joint. And I just wonder if as a group who's looked at that next tissue, the bone, not just the edema, but maybe the function of the bone, the mitochondria there, and again, then the muscle.
Nancy, this is Christian. So I'm not aware of any specific studies, but particularly looking at the mitochondrial function in this. We have looked at this kind of from a more macroscopic way. For years, we have tried to correlate some of these initial subchondral bone injuries, like after ACL injuries, for example, to the outcome, to the inflammatory load, to the to things like pain and function. And we have used the Moon cohort to try to do that. About 10 years ago, I used to go down to Nashville and basically looked at Kurt Spindler's data myself to try to figure out if the size, the extent, the grade, or the depth of the bone bruises would have anything to do with that. And none of that panned out. So while there is that initial injury to the subchondral bone that going through the articular cartilage, it doesn't seem to have a measurable clinical effect, at least at 2 and 6 years after the injury. The only thing that we could find was if there was a present defect in the articular cartilage overlying the bone grooves, an actual macroscopic defect at the time of injury, that seemed to have a weak association with a worse outcome. From a basic science perspective, Emily, my postdoc, Emily Hunt, did some work where she looked at some biomarker changes regarding Ig binding proteins, where she found that there is changes in the surrounding muscle, the VMO, pretty much right after ACL injury, which seems to be correlating with some of the inflammatory markers. So I'm sure there's some cross connections, but I'm not aware of anything going further into depth here.
Hi, Dr. Lane, and thanks, Dr. Lattermann. I can pop in quickly. For part of my dissertation work, I looked at the quadriceps changes, muscle physiology after ACL injury, and it's not exactly the same model as, maybe some of our military personnel, but what we're finding is that there is definitely changes in the muscle physiology that are unrelated to the neuromuscular side of things and more related to the pathophysiology of the disease progression. So like Dr. Lattermann mentioned, we found some important inflammatory pathways that were upregulated, as well as some muscle binding proteins that may be important in the disease progression in post-traumatic osteoarthritis.
Great, wonderful, thank you.
Christian, do you have any further comments on the role of synovitis in these injuries?
Yes, sure. Hang on a second. Do I have to unmute myself here? So I have to, can you guys hear me?
Yeah, I hear you.
Okay, I just had this thing pop up. So yeah, I mean, the role of synovitis is, and this is something that obviously I'm not the only one on this panel who has kind of sort of studied that. We studied that more specifically from in the ACL injury model, right? And so I'm a sports surgeon, so I see a lot of kids with ACL injuries early. And a particular study that really spiked my interest back in 2009 was out of Europe, Peter Verdonk. He looked at MRI scans, degenerate scans after ACL injuries, and he reported that there was a substantial loss of glycosaminoglycans and basically matrix very soon after ACL injury, as early as 2-3 weeks after ACL injury, that basically didn't really change over the first 3 months after ACL injury. And that really kind of vexed me, because I did not realize that a simple ligament injury that we would see all the time would have that profound an effect on the actual weight-bearing surfaces. And we started looking at the role of inflammation, specifically IL-1, right after ACL injury, and we did a couple of clinical trials that we used in order to essentially embed cohort studies where we would try to influence the level of IL-1 and that breakdown that happens after ACL injury. And this is the Moon AAA trial. We have published that. And what we did here is we basically followed a cohort of ACL injured patients, and we did synovial fluid draws 3 times within the first 4 weeks after injury. And what we found was that there was a profound degradation of collagen measured as a certain biomarker called CTX2 in conjunction with a significant upregulation of IL-1. And also a significant downregulation of IL-1RA. And as we were trying to basically correlate these findings to the longer term outcomes, we ended up finding that there was a subgroup of patients, which constituted about 1/3 of them, that had a what we call a dysregulated inflammatory response. So in other words, they had very low IL-1RA measures, pretty high IL-1 measures in the synovial fluid, and those were the ones that ended up doing worse at the 2-year time point. So after that, we felt that inflammation, and that is driven through the synovium, is actually a significant driver. Jody, can I quickly share a slide with everybody?
Certainly.
So let me just try to do this here. I know I can't do that, because otherwise we are losing the other slide sharing thing. Unless if you let me do this, then I just I share and quickly unshare.
Yeah, I think that would be fine, Christian.
Yeah,
we can bring it back up after you're done.
Yeah, I think we can do that.
Okay, so here's what I want to show everyone. You see this slide here, and what you see on the what you see on the top left, this is a knee arthroscopy. This is the lateral meniscus. This is the lateral femoral condyle, and this here is obviously synovitis. You also see this here. This is like a very, very strong walling kind of inflammation that we almost normally would associate with almost like an RA type of picture. This is a patella up here when you're looking inside that knee scope, and this is what you see. And then this one here, I want to show you that video. Let me just turn that sound down. And you see right here, as we are getting into this phase, this is a synovitic, kind of almost like an invading tissue that crawls over the trochlea here, and you can actually push this off, right? So this is all synovitis, and these are all patients 3 weeks after ACL injury. So this synovial tissue is very actively involved in that immediate post-operative cause, and that was one of the reasons why we started to get interested in that. Yeah, so thank you very much.
So I think we're back to the screen sharing of the discussion. Are there any other comments on the basic mechanisms, biologic mechanisms that might be responsible for PTOA? And we have some questions from David Felsen. Can someone comment on animal models of post-traumatic injury which suggests that strains with limited inflammatory response don't get OA? Perhaps Christian can comment. That's from David Felsen.
Yeah, so I'm not sure if I can answer that question because I'm not sure how readily translatable many of these inflammatory models are into the true human situation. There is certainly, all kind of different approaches that you can take to limit inflammation. And whenever you're looking at the histology of some of these models, you can see that you can limit the extent of inflammation to the point where these animals look like they have normal articular cartilage surfaces. We have seen the same phenomenon in a lot of animal models when it comes to things like cartilage repair, and it hasn't panned out. So, while I'm sure there's strategies, we see that, for example, you can go into various therapeutic agents, I think some of which you guys have discussed in the past already, that are trying to address that. I'm not sure that we see the same clinical effect. And I think part of the reason here is because that the inflammatory response is not just an experimental situation, but it also, and this is, I think, where that connection comes into play with the mechanical environment. The human knee, once injured, once the ligaments are injured, there's a lot of factors here that play a role. You have mechanical debris that can drive the inflammation. You have chemical drivers such as various different cocktails of cytokines. You can also have additional factors such as muscular weakness, which we know is associated with ACL injuries. And I think this is where the problem is. It is not just a single track issue like we would see it in an animal model. I think it's a combination of 2 or 3 different factors.
Thank you. Question from Terry McInerney to everyone. Christian, I remember one of your presentations also featuring glutamate levels and maybe related proteins in the ligaments and synovium. Is there any active work in that area? I think you're muted, Christian.
So this is one area that we had looked in at one point, not specifically in the ligament and synovium per se. What we were more interested in is what the actual cellular components are in the synovium. And this is active ongoing work where we are looking into single cell RNA analysis of some of these fibroblasts and also macrophage populations in the synovium. I don't think I can answer that question further. That's a little bit beyond my reach.
We have a comment from Martin Watts. Martin, do you want to provide detail on Arthritis Foundation tests of anti-inflammatory compounds, clinical trials, that is?
Yes, thank you, Jody, for giving me this opportunity, and also thank you very much, Christian, for pointing out a potentially very important role of inflammation. So I want to take this opportunity to inform this audience about the efforts that are ongoing and are supported by the Arthritis Foundation in the area of post-traumatic osteoarthritis. So there actually is a post-traumatic osteoarthritis research agenda, which is basically trying to address some of the key questions that were raised here already. And those include trying to identify perhaps subsets of patients that had joint injury and are at risk for more rapid progression, meaning that they could be perhaps great candidates for clinical trials, and obviously are patients that would be at increased need for an intervention. It is trying to develop biomarkers and imaging markers that actually can either be used as predictors of progression or as measures for treatment outcomes. And there are several individuals here on this call that are involved in this. Actually, Christian Lattermann was one of the first people joining this network. Cale Jacobs at University of Kentucky is currently involved there. And the two clinical trials that are ongoing right now is one trial that is using the anti-inflammatory compound montelukast. And Kurt Spindler at Cleveland Clinic is actually embarking on the study now to use Zilretta, the long-acting corticosteroid, in patients with post-traumatic arthritis. When this compound is obviously injected into the knee joint. So these activities by the Arthritis Foundation are addressing some of these key aspects, and we actually currently have, besides these intervention studies, also 3 projects that are looking at mechanisms. Actually, one of the projects is addressing post-traumatic osteoarthritis in the ankle at the University of Iowa. There is a study that's actually also looking at biomechanical interventions. I would encourage you to visit the Arthritis Foundation website, and you will be hearing about progress from these multiple studies in the upcoming OACS meeting later this year, and also through publications. So I think this is obviously a research effort that is in this arena and addressing some of the issues that Jody put up here as discussion topics. So thanks for listening to this.
Thank you very much, Martin. Julie Harris asks, does ACL reconstruction increase the level of synovitis and inflammatory markers, or does the level remain constant after the initial injury? If it is increased with surgery, is this a reason to pursue conservative management of ACL tears? So that is an interesting question. We know that joint surgery is essentially an insult to the joint. So I have to defer to Christian. Should we stop doing ACL reconstructions?
No, and maybe yes. So we actually have done a second follow-up trial after the Moon AAA study, where we wanted to know exactly that, and that was driven by Stefan Lohmander, who did a very interesting trial called the Canoon trial, where he randomized 2 different groups of patients, 40 patients each, with ACL injury versus with early treatment versus delayed treatment or no treatment. And he postulated that in his 6 and 10 years results, he found that those patients that did not end up undergoing ACL surgery, that they had slightly lower inflammatory markers and slightly better overall outcomes on the KOOS. And so what we did is we did a second trial where we got our patients early, again, within a week after ACL injury. We drew their synovial markers. We injected them with Kenalog at that time, because we had shown in our first trial that lowered the incidence of chondral breakdown. We could confirm that happened again in that group. And the idea was that after surgery, A week after surgery, we would tap them again, and then 4 weeks after surgery. And 1 week after surgery, we wanted to, we gave them an injection of a viscosupplement, hoping that that would, again, if there is an increase in inflammation and chondral breakdown, would potentially mitigate that. And what we found is that indeed, after ACL surgery, these chondral breakdown markers go way up, in fact, higher than initially after the injury, which is very consistent with the work that Jody Buckwalter has done over many decades now. And so the ACL injury does not really seem to behave a lot different from what happens when you have a pilon fracture in that respect. The bad thing about this is that viscosupplementation doesn't help. So it didn't change that at all. But what that basically told us is that the work that Stefan Lohmander has, and Stefan, I see him on the call here, hi there, that he had done with his Canoon trial, we basically provided that front end piece to it. So that is indeed true. The ACL surgery is potentially a second hit. Now, is every patient that injured his ACL a bad patient for surgery because of that? No, absolutely not, because there are some patients who are grossly unstable after ACL injury and they require a stabilization of that joint. But some others can make it work. That has to do with the overall alignment. Generally, patients who are slightly valgus aligned probably do a little bit better. It has to do with the extent of the injury. It also has to do with the type of sports and activities that they go back to. To try to tell a running back to try to do his job without an ACL, that is not going to happen. If you are a cross-country skier, that's a different story. And that has a lot to do with the decision whether an ACL should or should not be repaired. Is non-operative management potentially the better option with regards to post-traumatic osteoarthritis? I think the answer to that is maybe. But you have to take other factors into account. And this is why it is so important, I think, that we understand what the role of that immediate reaction to injury and surgery is in terms of inflammation and chondral breakdown. And I think surgery is not a bad idea, but it can't be the only thing we do. What we need to do and understand as surgeons is we need to add to that. And particularly in those patients that we feel are under a greater risk of developing post-traumatic osteoarthritis, they may need additional treatments with injections that may be anti-inflammatory preparations, that may be things like PRP or stem cell treatments down the road. I think orthobiologics will play a big role in this, but we need to study that.
Thank you. There have been a couple chats that went to everyone, and I'll just quickly summarize them. Kale Jacobs, thanks everyone, love the discussion. There have been some recent studies that suggest that underloading the joint after ACL reconstruction is associated with increased cartilage breakdown, whereas Dr. Marshall brought up the concept of overloading and added weight carriage increasing the likelihood of PTOA. What are the panel members' thoughts on underloading versus overloading? And Ken Cameron said, I agree that we may better conceptualize this. Sorry, I got blocked. We may better conceptualize this as optimal loading post-injury and reconstruction rather than overloading or underloading. What is our current state of understanding? Well, second question, or second point, what is the current understanding of the potential role of cell senescence in the pathophysiology of PTOA? So concerning the optimal loading after joint injury, Jason, do you have any comments on that?
We were playing tag with the mute button here.
Oh, sorry.
So, I mean, I think what we've heard kind of suggests that there is potentially a window in there. In terms of the ankle, I think there's potentially some different circumstances than you might have at the knee. Some of the work that we're doing right now with computational modeling suggests that with some of these external supports that we might be able to get them essentially bracketed in a specific window by providing enough support to prevent overloading while still allowing them to be active and engaged in activities.
Thanks. We'll have maybe perhaps one more comment. This is from Carissa. Thanks for the discussion. I'm currently a graduate student at UC Davis studying OA pathobiology and cartilage immunology. Can someone comment on the difference of immunogenicity of allogenic cartilage implants versus the immunogenicity of Ptoa chondrocytes? And I forgot, I'll have to come back to cell senescence, but any response to Carissa's question? Christian, do you have any comments on immunogenicity of cartilage transplants?
So I think I can maybe say something about a part of that. I do not know much about the immunogenicity of Ptoa chondrocytes. Allogenic cartilage implants, we've known that for many years, that they do elicit actually immune responses when they are being transplanted in our patients. So if you're looking at the humoral immune response, that does happen. That in fact happens for any allograft tissue that's being utilized in sports medicine. But what it does not do, it does not result in an actual cellular immune response to it. So as far as I understand, there is no true rejection response. The one thing that has been postulated for some of these allografts is potentially that you can get a graft versus host response. However, we try to mitigate that by reducing the actual amount of subchondral bone that is being utilized in these implants to an absolute minimum. In fact, there's even techniques out there and technologies that allow us to remove the fat out of the subchondral bone in order to reduce that further. That's about as much as I can say about this.
Okay, thank you. And then the issue of cell senescence. Martin, if Martin's still on, he certainly may understand it better than I do. But we've done some studies on human articular cartilage and found that with increasing age, there's an increasing percentage of senescent cells. We also did some basic work showing that chronic oxidative stress was associated with telomere shortening and the onset of chondrocyte senescence. So Martin, do you have any comments on that?
Yes, so obviously there's solid evidence for an increase in senescent cells in primary age-related OA, but actually it initially came as a surprise when the study by Jennifer Eliseev showed that in the PTOA model in mice, they actually, in young mice, they discovered that there was also a rapid emergence of senescent cells soon after the meniscus destabilization. And moreover, of course, in those studies, they were then also to demonstrate a pathogenetic role of senescent cells, because treatment of mice with meniscus destabilization not only reduced the number of senescent cells, but actually reduced the severity of cartilage structural damage. So there's several other animal model studies that extend these observations, and also elegant work by Kirkland showed that actually transplantation of senescent cells into normal mouse joints can actually aggravate osteoarthritic changes. So there's strong evidence for a pathogenic role of senescence, and actually also in the setting of post-traumatic models.
Yes, I think that's really an exciting area. So perhaps we can move on to the next topic. This has been really great discussion. So the next topic is identifying who's at risk of mechanically induced osteoarthritis. And that's important for deciding who needs treatment and for clinical trials. And I'll just briefly summarize our interest at Iowa has been in intra-articular fractures, particularly the pylon fractures. And we decided to do that because those injuries lead to post-traumatic osteoarthritis in a high percentage of patients within 2 years. So we could anticipate doing clinical trials with a relatively reasonable time frame. But of course, we needed to stratify patients, and Don Anderson and his team and others at Iowa developed the technology of looking at the liberated fracture surface area in pylon fractures, and showed that that correlated very closely with the risk of PTOA within 2 years. So the higher the energy of the fracture, the more likely somebody would develop PTOA. And in fact, it was powerfully predictive. So Don and his group have gone on to show that fracture energy as measured by liberated fracture surface area. Oh, well, Don's on the call. Don, do you want to comment on that rather than have me do it?
Well, Jody, I think you're doing a great job. I wouldn't necessarily hop in here. I do think that anytime you're talking about joint injury, it's important to distinguish different injury severities and how they might influence PTOA risk. And if you can't control for that, it makes it very difficult to do clinical trials of interventions. So I'm glad you've raised the point, but I'll pop off the mute here and let you continue. Thanks.
No, I just was saying that it's really helpful, and we're hopefully going to start a clinical trial within a few months of, well, a 2-center clinical trial of treatment of post-traumatic or of injuries, pylon fractures, and we'll talk about treatments, but it's this risk stratification that lets us know who is likely to develop OA in a reasonable period of time. So it's been a very important, in a sense, a biomarker of who's at risk. I need to mention that Emily Hunt added a comment that Heather Faust has just published a paper in JCI looking at the response of Th17 immune cells and senescent cells in a PTOA model. Very interestingly, the paper found that immune cells release an altered SASP after ACL transection. So it really fits in nicely with the whole issue of senescence and what are the role of these cells in PTOA. So I've mentioned intra-articular fracture risk stratification. Let me ask Christian, do you have, can you predict who will develop PTOA relatively rapidly after an ACL or meniscus injury? So I'm talking about intra-articular fractures, which are a small set of all of the causes of PTOA.
Yeah, so the short answer is I don't think we can at this point. You know, for some things maybe, and you can certainly get a clinical notion with a clear intra-articular fractures, you know this is going to happen and they certainly are at risk. But when you're talking more about athletes or, you know, combat athletes, you know, acute ligament injuries, for example, we do know that they are all at risk for OA, but the ones that you're really looking for are the ones that are the fast progressors. And we do feel that mechanical instability really plays a role in some of these, but a lot of them get adequately stabilized and they are still progressing fast. And I think these are really the ones that we need to tease out. So it is not all about, you know, the early stabilization treatment, and it comes back down to the combination of mechanical and chemical injury to that joint. It is not feasible to go ahead and take synovium on every patient that comes into your clinic, so we need to find better markers, and unfortunately the serum markers for these acute injuries have not really been helping us to this point.
Well, that's been my impression, Christian, that we really don't have good methods of predicting who will develop PTOA after an ACL tear, at least within, you know, literature much better than I do. We know over 20 years, it's going to be a high percentage, but who is going to develop it rapidly? I don't think we have a good way of predicting that.
That is correct. There's some efforts that I'm aware of that have looked into ratios of IL-1 to IL-1RA in synovial fluid, and there's other efforts that have looked into that ratio in serum. And in serum, this really hasn't panned out. This was work that was done by Biomet. And in the synovium, we could see that, but again, it is not feasible to go ahead and just tap everybody's knees all the time. That is just not a clinical strategy that we can do. So we need to do better. And I think imaging may give us a big clue here. I'm not sure if we have Shamila or somebody on who could talk to that.
Well, I guess, I mean, that's been a hope, is that MRI might give us a biomarker of who's going to develop OA, but my my understanding is thus far, it hasn't been proven to be at least useful in clinical practice.
Yeah, Jody, this is
Sorry.
Nancy Lane.
Sure.
I can't speak for Sharmila, but I'll try to summarize that. Yeah, it looks like MRI can tell us a lot about, the stages. I think the cartilage water is going to end up being important once it can be regionalized into an area at risk. But I don't think without some sort of fluorescent markers, maybe PET CT will allow us to. We're not going to get a real idea of who's going to be at risk.
And I think that's one of those areas that it would be so helpful if we did have a technology or a method to let us do that.
Yeah, well, I would ask anyone on the call if anyone's had experience doing PET CT with FDG or other of the reagents in a patient with post-traumatic OA, either acutely or within a few months or after surgery, and if it's been at all helpful in terms of prediction, because that actually is going to get you kind of the inflammatory burden and the tissue damage burden without going into the joint. Now, how that translates then into deterioration of the tissue, I don't know. But I would say that's a ripe area for investigation.
So to sort of summarize, in intra-articular fractures, I think we have a really good technology for predicting who's at risk, but in most other joint injuries, at least thus far, we really need further work, and that's probably a high priority area for future work. There aren't other comments on methods of identifying people at risk. Hearing none, maybe we can move to methods of preventing joint injury and overloading. Ken or Steve, do you have comments on strategies to prevent joint injury or overloading?
I think I'll let Steve field this first.
Okay.
Thanks, Ken. So from studies of athlete populations as well as studies of active military populations, we do have some techniques for how to identify the people who are going to sustain injuries. And of course, the single biggest predictor of injury is that you're in a high-risk occupation or playing position or sport. So not surprisingly, the occupations that involve more manual stresses to the body, and especially people who are placed in active deployment theaters, at a much higher risk of injury. Even when they're not actively engaged in combat, they're at higher risk of injury just by virtue of being deployed. And I think those of you who've been through deployment to active theaters can understand that, being shot at and blown up is no fun, but there's also substantial amounts of time when you're kind of, to be blunt, sort of sitting around waiting for things to happen. And, we probably need to offer people less dangerous forms of recreation in forwards combat situations. That would definitely make a big difference. Beyond that, Ken and I have spent a substantial amount of our careers looking for the indicators of human movement that would identify who's predisposed to injury. So in the early days of research on ACL injury prevention, the thought was that when someone has an ACL injury, there's often an extreme valgus movement in the knee. The sports-related ACL, at least in a game like football or basketball, not so much skiing, sort of has this very distinctive valgus collapse where the knee pivots inwards. And people identified this as perhaps they could see people who had that movement pattern pre-injury as well. So the connection intuitively was made for people. However, it turns out this valgus motion is post-injury in the microseconds following injury. And you can probably walk around as knock-kneed and bow-legged as you want. It's not great for you, but it does not identify who's going to tear their ACL. The orientation and movement in space of the hips and the pelvis does identify who is going to tear their ACL or their meniscal and have meniscal injury. And if you think about the knee, it's like the middle part of a skyscraper, and the ground is at the bottom and the trunk is on top. And the knee is essentially the hinge where all of the stresses and forces come to do their carnage. So it's what happens at the top of the structure biomechanically that predisposes, and how the foot is placed on the ground, that predisposes the knee to injury during running, jumping, and a lot of other military relevant tasks.
Well, thank you. Are there comments on methods of preventing joint injury or overloading?
Yeah, I think just to add to what Steve said real quickly, I think there's been a lot of work in this area. It's all pretty promising. I don't think that there's a one right answer, and I think that the OA Action Alliance infographic that I shared during the presentation kind of captures that. You know, there are some critical components that probably go into injury prevention that need to be incorporated if you're going to go that route. I think we have a problem with people actually utilizing the evidence and implementing these types of activities. And you know, we still have some questions about the dosage, the timing, and when these things should be applied, and you know, whether or not we need to, you know, retrain or maintain those changes. So I think there's some big questions around that, but I think there's definitely some promising evidence that this might be a way to prevent injuries in the first place, particularly those that happen, that are non-battle related injuries that lead to post-traumatic osteoarthritis in military populations, but also in athletes.
Well, thank you very much. Unless there are other comments, I'd like to move to treatments of joint injury and early OA.
Can I ask one question? And I think that would probably address Ken and Jason, I guess.
Sure.
So I work a lot in the patellofemoral joint, and the patellofemoral joint is one of those that probably suffer most from overloading. And I've been wondering for a while, and you can keep this really short. Is there any evidence that some of these exoskeleton kind of spring-driven devices that take away some of that load during squatting and getting up out of a squat on the patellofemoral joint, can those actually physically unload a patellofemoral joint? Have you guys got any experience with that?
I know that some of that technology is out there. I don't know that anybody specifically looked at that aspect of it, would be my short answer.
And I would echo the same answer. I'm not aware of that research. And one of the challenges is estimating those joint reaction forces during those types of activities and getting an accurate estimate.
Well, thank you very much. If we're in agreement, we could move to treatments of joint injuries and early OA. And I'll just briefly summarize our approach. I mentioned earlier that we've been looking at oxidative stress, both in its role in acute joint injuries and PTOA, as well as chronic overload. And in a series of laboratory investigations, as well as animal studies that closely duplicate human injuries, we found that methods of either scavenging reactive oxygen species with N-acetylcysteine or reversibly inhibiting electron transport, mitochondrial electron transport, could prevent PTOA in a large animal model of intra-articular fractures. In a paper that was the first author is Mitch Coleman from the University of Iowa. So based on that, we were funded to start a clinical trial treating pylon fractures with ammobarbital at two centers, University of Iowa and the University of Indiana, in an effort to see, first of all, safety and some measure of efficacy. But if inhibiting this oxidative stress and mitochondrial dysfunction would actually decrease the risk of PTOA. So that's a very brief summary of a lot of work of the people at the University of Iowa on methods of clinically applicable methods of preventing post-traumatic osteoarthritis. And as I mentioned, our focus has been on intra-articular fractures, which, as Nancy's pointed out several times, is a different problem, very different problem perhaps than an ACL injury, although understanding the mechanisms in one type of injury may help us understand the other. So that's an overview of our look at it. Nancy, do you want to comment? And you wanted to comment also on PTOA versus age-related OA and their treatments.
Yeah, we thank you, Jody. Personally, I'm not doing any PTOA studies with interventions right now, but I wanted to bring up that in the aging OA world, we're seeing a number of compounds that potentially could be tested and might actually work better in the PTOA individual than in age-related OA. And one is a senolytic agent that has been studied by, brought to market or to study by Unity Biotherapeutics. And that actually was a study, intra-articular injection of a senolytic agent. And although it didn't appear to work to reduce pain in a phase 2 study, the structural endpoints for that study are still being evaluated. But based on the information that's come from a number of laboratories now, that PTOA is associated with some senescence within the cartilage tissue. And maybe a senolytic at that point early after injury might be an effective therapy or have some effect. It definitely, I think, should be evaluated. Another area of interest right now in age-related OA that, again, might be applicable to post-traumatic OA is the recent study by Novartis published in Annals of Internal Medicine showing that individuals with a highly sensitive CRP that was elevated and that were given IO1 inhibition for 5 years as a secondary endpoint of another study showed reduced joint replacements. And again, it's possible that maybe those PTOA patients who have some systemic inflammation might be a subgroup that we could use, say, an anti-cytokine therapy to preserve their joint. Now, it is a problem that we talk about a 35-year-old having a treatment. How long would we treat them? I don't think that most medical plans would allow 30 to 40 years of treatment. So I think if I take a page out of the bone osteoporosis world, we may need to treat and then also to prevent further deterioration. Those may be two different types of therapies. So lots to sort of chew on now in terms of how to best approach this group of patients. And those are just two of the many therapies being studied today that I just wanted to bring to your attention.
Thanks, Nancy. That's really insightful. Christian, could you comment on steroid treatment of joint injuries?
Yeah, sure, I can. I mean, the one quick comment that I want to make up front, I was actually very intrigued by the paper that Nancy just mentioned. The only problem is the annual cost on this is $70,000, and I think that in itself is already cost prohibitive. So we need to do better than that. So we were actually looking into one of these interleukin-1 blocking agents when we were doing our initial clinical trial, and then for FDA reasons we couldn't do it. And so coming back to actually this panel, pretty much quite a few of the guys that are here today were there when we did the snow conference in Chicago. We basically decided then to go with triamcinolone acetonide instead in patients acute after ACL injuries. And these patients would get a triamcinolone acetonide injection, 40 milligrams, which is a standard dose that we use in orthopedics, as early as 4 days after ACL injury. And in some of these patients, a repeat injection a week later. And what we found was pretty interesting. And every patient out of the 4 test groups that received triamcinolone acetonide within the first 2 weeks after ACL injury had a significant reduction in CTX2 values. So in other words, they showed much less collagen breakdown over these first 4 weeks than the control patients that only received saline. To tell you the truth, that surprised me because I didn't really expect that. I still don't fully understand why that is, because I'm not 100% sure that I understand why triamcinolone has that effect, but as a matter of fact, it does. And because we did trust the data, obviously, but I was a little suspicious and I wanted to repeat that. And we did that in the second trial and we saw the same results. So we have 2 trials now with close to 100 patients that basically show that effect. And so I think that is real. The problem is that triamcinolone acetonide is a little bit like shooting cannons at birds. And you know, while I like that effect, I'm apprehensive to do that in my clinical practice on a regular basis in the 15-year-old who comes in with a fresh ACL tear. I think we need to be a lot more targeted than that. Again, you know, I tell everybody and then I implore everybody to basically utilize the Arthritis Foundation setup to study these kind of things and look into things like orthobiologics or potentially more targeted IL-1 inhibitors, for example, to look at that effect, because I do not believe that triamcinolone going forward really is going to be the solution to that problem.
Well, but Christian, this is Nancy Lane, and I congratulate you, because getting the inflammation down is critical, and potentially, you know, every 6 months, some triamcinolone for a few years might be fine and probably wouldn't be terribly detrimental. The good news about IL-1 inhibitor is it's going off patent. So maybe we can work on determining the frequency that one might need to demonstrate efficacy. But at least as we're thinking about something that would be a few years, you know, a chronic therapy, but hopefully not too often, not frequently required. But that would have to be in a 15-year-old or 20-year-old. It would have to be in addition to some sort of rehab and muscle training, right? I would see it as a comprehensive type of of therapy. Yeah, multimodality. Yeah.
Absolutely, there's no question about that, and that's what I alluded to earlier. Is this surgery may be one part of it, rehab is one part of it, injury prevention is one part of it, and intervention against inflammation. I think those 4 have to go hand in hand together, and then we may be doing better.
Thank you. Jason, you've already mentioned orthoses and bracing, but perhaps you could make just a few comments about the potential role of these specialized braces in minimizing the effects of a joint injury long-term.
Yeah, happy to. And I do want to point out that there was a previous forum session where they did a really nice job covering the benefits of exercise and rehab, and encourage people to check that out also. And just to maybe as a point of clarification, when we're talking about some of these braces, I think people tend to think of a kind of narrowly focused ankle brace, but we're talking about something much more robust, something that spans the ankle joint and is able to largely replace the function of the muscles or support the joint so that the muscles don't have to generate as much force, which in turn decreases contact stress. And so what we're finding in some of our clinical work is that in a cohort of over 30 individuals, we saw pretty dramatic reductions in pain who were experiencing mobility deficits and pain due to ankle arthritis. And so once that arthritis is set in and they have the pain, the reduced activity, there's a lot of effort that goes into getting them mobile again and getting them engaged. I like the analogy of activation energy in a chemical reaction where the more painful it is, the more impaired they are, the harder it is to get them back to that level of activity that you're looking for. And so with the external bracing, what our data suggests and the positive clinical outcomes we've seen is that by providing the support, you can reduce initially the pain, which allows them to be more mobile and allows them to potentially effectively load the cartilage and decrease some of the symptoms over time.
I think that's just fascinating direction. And I wish we understood better the effects of loading and motion on injured joints, but certainly this is an exciting direction. Are there other comments about treatments of joint injury? We've covered a spectrum from suppression of reactive oxygen species and maintaining mitochondrial function to steroids to other anti-inflammatories to orthoses, and senolytics. I also wrote that one down, and treating senescent cells. So Steve, you had a comment?
Oh yes, thank you. Yeah, all these approaches are fantastic and really good and innovative and novel, and absolutely all of this work needs to be done and utilized in clinical settings. I thought it also important to mention, I hate to say it, but simple patient counseling is a really important technique. And I guess more broadly, patient equity-based approaches and empowering patients to have greater self-efficacy over the loads or lack of loads that are placed on their joints, either through weight gain or healthy weight, maintaining healthy weight, but also through their occupational and recreational activities. Educating our patients to take control of their condition can be a really important and relatively low cost technique that we shouldn't overlook, in addition to all of the things that we've discussed here.
Thank you. Any other comments on treatments? If not, perhaps we have enough time for each panelist to pick one future research direction that they think is high priority. I'll start. I think finding better ways to assess the risk of post-traumatic osteoarthritis and injuries other than intra-articular fractures would be extremely valuable in moving the field forward. But if each of the panelists would care to pick a direction. Ken, perhaps?
Yeah, so I won't necessarily pick a direction, but
okay.
Last year at the Extremity War Injury Symposium, it was announced that congressionally directed medical research program had decided to fold post-traumatic osteoarthritis as a focus area under arthritis in general. I know that the Arthritis Foundation and other agencies have really tried to focus on getting OA as a separate funding mechanism through CDMRP. I think that really needs to be an effort. I think we've seen from the presentation today, from a lot of the great work that Jessica's done, that this is really an area that impacts the military. It impacts our military readiness. Yet it receives a very small amount of funding, and even probably less now that it's been kind of folded into other programs. So I'm not in a position to advocate for that, but I know that some people on the call may be. So I think that would be my area for future directions in research and supportive research.
Well, that's really a good point. Christian?
I would think that what is really essential for us, and this is speaking also as a cartilage surgeon who deals with joints that are kind of in the middle course of OA, if you want so, is we need a measure of inflammatory burden for these joints in order to predict or improve our chances to treat these patients in the mid stage. And I think, that's one of the areas that we'll be looking into, is that needs to be some sort of a combination between biomarkers, between imaging and potentially physical attributes that some of these joints show us. I think that would be a real game changer if we were to put a number to the inflammatory or the osteoarthritis burden that a joint is in order to correlate that to our treatment outcomes.
Great, thank you. Steve?
Yeah, so many things. I just don't know what to pick out. Sorry. I need to have about 5 or 6. I know that's not fair. In public health, we kind of think about primary prevention, pre-injury, secondary prevention, which is post-injury, but before PTOA develops, and then tertiary prevention, which is mitigating progression. Once PTOA has been diagnosed, mitigating its progression. And I think what we really need to do is identify intervention approaches, be they basic science or behavioral, that work across all three of those domains. Because if you can work on reducing risk factors early in life, that will pay off across the whole lifespan. So I think, kind of things that where you make one change and it has multiple positive benefits are important to focus on, be they basic science or however.
Great. Thank you so much. Jessica?
Yes, sir. I would be also very hard pressed to pick one direction. As a person who now is mostly taking care clinically of traumatic and post-traumatic things, I would say, geez, it would be really great to know more about how to get a joint recovered after an intra-articular fracture. That being said, based on some of the things that we've talked about in this forum, it is clear that for my generation of veterans and those to come, that the occupational hazard is not going to go away. We cannot change the U.S. military's demands in terms of the training required of them, the loads they're going to have to carry, and the exposures that they're at risk for. So that understood, I would refer back to the prior comment on primary prevention, and I would say perhaps a very useful direction forward would be, how can we prehabilitate, if you don't mind me using that word, our service members in their entry-level training and their occupation-specific training to treat them as athletes that for whom we would like to prevent these injuries.
Thanks very much. That's great. And Jason?
Yes, I think I'd refer back to our early discussion about defining optimal loading. I think from a rehabilitation standpoint, figuring out how much load is too much, potentially not enough, and when specifically in the rehab process those loading conditions are most appropriate.
Well, this has been a really great set of discussions. I really appreciate the expertise and the participation of the panel members. It's really been stimulating. It's given me a lot of new ideas. I hope it's been beneficial to the participants and as well as the panel members. I think it's really been a very provoking set of discussions. So Jason, Kim, I guess I turn it over to you now.
Yeah, thank you, Jody. Thank you, everybody, for joining in today's discussion. It was a fantastic discussion, and thank you, Jody, the panelists, and our attendees for making this a great session. And we're just so happy that we could cover this important topic. At this point, I'd like to also recognize our internal staff for helping with a smooth program, particularly Emily Hunt and Caroline Lizet. But also we have a little logo here from the ATOAC, and Caroline will drop in some links regarding that. They were critical early on in just helping us assemble some of the panelists, especially some of the harder to reach panelists that are on here. So thank you for that, and we're really happy that they could be a great friend of the Arthritis Foundation, and hope that you guys will support them as well. We'll make this recording available pretty soon. So I know there's been some questions about if the presentation and some of the discussion can be shared. So just check back into our website about that. And at this point, I'll also remind again about our December conference chaired by Tuina Nioji. We're featuring rising star speakers, video posters, and then the two forum series discussions. Corporate scientists speak on disease-modifying OA drugs with Lee Simon and Nancy Lane, who is on this panel, and learnings from the largest cohort studies with Kurt Spindler. So if you've registered for this meeting, you'll certainly receive an invitation for the next one, or the conference. And the invitation should also contain other links to help find out more details about this recording, as well as other past recordings. So from here, we're going to be transitioning to our networking breakout session with our volunteer host, Patrice Johnson. And I think some of our panelists will also be joining for that. So especially for the maybe shy folks out there, please join us for that and, ask the questions that you didn't get to ask in the main recorded session. So thank you again. And until next time, thank you, everybody.